University of Science and Technology in Irbid, in Jordan, in 2000, and completed her training in pediatrics at the same institution. She is a specialist in neonatal perinatal medicine and in developmental pediatrics, and earned her master's degree in health profession education in April of 2009. She practices as a clinical neonatologist and developmental pediatrician in the neonatal intensive care unit at the Sunnybrook Health Science Center, as well as at the Down syndrome clinic at the Hospital for Sick Children, which we were able to put together, and it started functioning in January. Her areas of interest include the long-term outcome of children with neurological disorders, preterm babies, and children with congenital anomalies. She also has a special interest in promoting and advocating for children with trisomy 21, and received the Audrey Tandai Humanitarian Award for helping families with Down syndrome children in 2007. And I'm so glad that Rudena was able to come here, because she's really knowledgeable in developmental disorders, and she will talk to us about the developmental and behavioral phenotype of children with nicolaides baraitser syndrome. Rudena? It's okay.
Hello everyone, thank you for having me. It's really a pleasure to be here. I'm also, in addition to that, I'm a mother of an 11-year-old boy who has Down syndrome. And I think I know a lot of parents and individuals with intellectual disability, which was all under one umbrella. So I can move from the physician hat and remove it and put my parent hat as well, and relate when we start talking about intervention and therapy. I looked at the same literature that everyone looked at, and please, looking at your children, I can see that not everything written in the literature is right. And it tells a lot, that there's a lot of things that we need to look at, and there's a lot of things that improve my theory about development. So please feel free to interfere at any time. The answer about research and why now we need to look more about this group or intellectual disability. Like since 1993, people start knowing and research looking more about nicolaides syndrome. But also at the same time, there's a significant advance in healthcare. There's also early intervention and family care. And the families, in the last 20 years, they start opting that they want to raise their disabled children along with their peers, as well as along with their typically developing children. In addition to that, there's a major changes in the law of education. 20 years ago or 30 years ago, children were taught in a special schools. They were even residential schools. Now, they have the right to be fully integrated and fully educated, which also put the demand that we have higher expectation as a society, schools and educators, that we have different expectation for children and individuals for intellectual disability. We're not just only looking at integrating them, we're looking at education, employment, and also community living, and having them independent and living up to their expectation as much as they can. And the terminology also changed, that we're looking at function more than IQ. So, sorry, I have two computers here, and I'm not a technical. So here I have no conflict, except I'm really interested to come. So in this, I'm gonna talk about the physical quickly, but I'm gonna change it. I'm gonna do the application for a clinician and a developmental therapist, a pediatrician, why these features important to me. When you look at my slide, it's very similar to Dr. Ijaz's slide, with a different, just like the type, the style. But I'm gonna talk about if I'm a clinician in a clinic and I receive a diagnosis from Dr. Shidia, how can I look at it differently? Also, I'm going to talk about cognitive and neurodevelopmental profile, the goals of known early intervention, and family support. So now, how we look at individual with intellectual disability, the people first. They have the same right and need like everyone else. We know that their development is influenced by the quality of care, education, social experience offered to them, just like everybody else. When we look at development, and when we say the word development and behavioral phenotype, if we look at all of us, what makes us? We have the individual, which comes from our genetic makeups, which come from our parents, from like ancestors and that, what make us. Our physical features, the medical condition that comes with the physical feature and the genetic makeup, or if we have any other medical condition that we acquired along the way of our life. And all the three of these, how they affect our brain development. Then we come to the environment. We have the medical care, we have the family and community we live in, social education. All these affect who we are and how we're gonna develop. And also, when we look at the child developmental needs, it's very complex. How there's too many things affect the child development. So there is first basic fact about development. It's not fixed by gene at birth. Development is a dynamic, social interactive process. Development is influenced by the social learning opportunities, by the social support for learning, self-esteem, curiosity, and motivation to learn, and the biology and experience interact together to influence the brain development. Also, the input and activity from the brain influence the brain activity. And this is how we now looking at the brain plasticity and how they recover from any brain injuries, even how we have the chromosomes. Yes, we have the genetic makeup, but how the brain is plastic, we know that there's a lot of things that the brain keep developing, and it does not stop as we thought before till age of 5. It continues all along the lifespan. So now we come to what's going on with our children, that they have the nicolaides baraitser syndrome. These are the same what Dr. Ijaz said. We know them, and I'm not gonna go through them because she already talked about this one, that it is rare to affect anybody, and there's less than 100 cases confirmed. And the physical feature and the medical problem associated with this syndrome can vary widely from child to child. And just looking at your children, I cannot disagree with that. What causes this? We know it's like a mutation in the NCBRS2 gene, and it is part of the Fab chromatin modulating complex. It's also recorded in chromosome 9, and there's no familial cases, no consanguinity, recurrence is very low, and the chromosomal analysis usually is normal. So the major features, and I divide them to two things. Usually, the first 5 are the presenting feature. This is, I'm sure, you guys went to the doctor because of this. Because either we have intrauterine growth retardation, when babies, during the pregnancy, they were small. After pregnancy, after they're born, they're small, it's for gestational age. They have severe developmental delay, impaired speech, or seizures. And then make the clinician look at them and see, oh, they have these facial features and body features, and they, basically the process of diagnosis started. Are we all agreed? This is how we end up at the doctor's office? Okay. So then, the typical features of the syndrome. So when I want to talk about the features, when I talk about the triangular face, and I want to talk about the facial feature, the upper lip, the lower lip, the wide mouth, I think about speech. And I think about hypotonia. And I think that this is how gonna affect the quality of speech, articulation, that's gonna come from the child. Yes, it's a common feature for this syndrome, but as a developmental pediatrician, and to talk to my speech therapist when we're gonna talk together, I was like, look, this child has upper lip are thin, lower lips are thick, they have the hypotonia, the mouth is open, I don't know if the tongue is coming out, so when we talk about speech, If the child has developed speech, we need to know how we're going to talk about articulation, prompting, in order to pronounce the right sounds, and not to all just look at word approximation. When we look at the teeth, this is one of the things I look at, is also speech, because we have widespread teeth, and when we need to pronounce certain sounds, we need the teeth and the tongue to be at certain position. So if the child is speaking and I'm working with a speech therapist about the TH sound or the F sound, you need to make that, look at all its adult sounds, like what's going on with the mouth and the teeth. Also, delay eruption of the teeth and baby teeth, abscesses, if they have pain, that will look at behavior. Is that behavior because there is something wrong with the teeth? And also put at what they call maintenance guideline. Dentist is one of the lists that I have to make sure that it's part of the team that working with the child. The hair, I will not talk about it when I think about other than cosmetic and how they look, they're all cute. I don't think there is developmental implication to it. The skin is important because of eczema. 1/3 have sensitive skin and eczema. That is itchy. With eczema and not treated eczema, it can cause like bleeding, dryness of the skin, infection to the skin, and that will cause behavioral. Non-verbal children, if they are having itchy skin, they're going to be aggressive, hyperactive, and this can affect their behavior. And it's not because they're bad kids or not behaving, they're in pain. The hand and feet, the way how the progression in the disease will also alert me, and also if I'm working with an occupational therapist or with a physical therapist, how this can implement the function of the hand and feet, especially when the demand is higher, that we need more hand function. Hand is not only to grab things, it's for self-care, for feeding, for also like handwriting, for like all that things that happen at school. Then these things, when I look at them, it's like how medically the child is involved. How many times the parent has to go in and out to the hospital. How many times they need surgery. Hernia, endosyndactitis, scoliosis, cardiac problem, vesicurethral reflux have increased risk with urinary tract infection, multiple lipidemia, and abnormal creatine profile. All these just give me as a clinician and a developmental pediatrician how many visits and how critically ill this child is. Then we come to the growth, which also goes with the physical features as well as with how much the nutrition, how much nutrition the child is taking. So 45% have low birth weight, and as a neonatologist, is this a reason to be admitted to the intensive care unit and being taken and interrupt that time with the family, which really affect attachment and how the development of the child. Also, short stature is very common. Growth is less than 50% in all of the children, but there is no evidence of disproportion, and microcephaly. And when we look at microcephaly, there's at birth and then 82% later, and that can give me an idea how the brain is development. Is the brain is developing in the right way, and how that will affect the overall cognitive of the children. Then the other thing, how it affects the health, we know that 1/3 of the kids have hypotonia, which is low muscle tone. And low muscle tone can, in the infant period when they're very young, it can have poor sucking, poor feeding problem, which is common up to 50% in the children, constipation and digestive issues, which could carry on all their lifespan. And this can be a very good reason for behavioral problem. And choking, which is also can alert for make sure that they don't get sick, no admission to the hospital. And this is also alert me, do we need to do further investigation, like feeding study, as well as do we need to involve an occupational therapist with feeding expert. As they get older, the hypotonia can cause motor skill delay, adaptive skill self-care and delay, like feeding, dressing, and toilet training, speech delay, and constipation as they grow. Hearing loss is not common, is uncommon in children with the syndrome, but is something that we need to exclude, because if I want them to develop speech, they should hear very well. Vision as well, they have 16% with myopia and 6.5 with astigmatism, and these also can affect the input that we need to look at. Epilepsy, it's also important. We have 2/3 of patients develop epilepsy. There's different type. The response to the medication is variable. Usually the average start is around 1.6 years. Seizure is being associated with decline in speech and cognitive function, although one report with the monozygote twins said that there's no correlation, as one twin have seizure and then decline in cognitive function, the other twin have decline in cognitive function and then develop seizure. So this is an area of really to be looked at and investigated in terms of the long-term outcome, and I know there's a speaker going to come and talk about it in details. But we know that children who have uncontrolled seizure can affect their global development and also can have decline in their developmental output. So here when we look at development, we know that the syndrome can affect the kid's development, the kid's ability to develop in different way, and there's a wide ability of their, like just looking at your children. It can affect their cognitive skill, communication and language, adaptive skill, social behavior, and motor skill. And I put them in order to see, just because what's most is effective. So the least one is affected is really the motor skills in this population.
Excuse me?
Yes.
Just on the page before, I noticed that there was a comment, maybe it was the one even before that, that there was a comment about carnitine, possible carnitine sensitivity.
Yeah.
But then on the other page it says sodium valproate is a choice, but the problem is the valproate can cause the carnitine deficiency as well. So
that's why I didn't mention it.
that's why you didn't mention it.
No.
Oh, okay, because I just wanted to make sure everybody was aware that it's important to get a carnitine test if their children are on valproate.
Yes,
we ran into that with Mikey and it was a nightmare.
Yeah. And I really didn't want to touch more in the epilepsy and seizure because I know there's like a speaker come and talk about it, and he would be the expert. So that's why I just quickly moved.
Okay.
And this is what's been in that big study in 2014. They mentioned that sodium valproate is the first choice. Yeah.
Okay.
So this is where I got this line.
Thank you.
Yeah. So when I look about cognitive and learning, I want you just to look at this to see how the process is complicated. It's not only one factor that can affect cognition and learning. When we look at, in particular, in kids with this syndrome, it's one of the main features, and some of the time it's a main presenting feature. The definition of intellectual disability and adaptive dysfunction is an IQ less than 70, and usually it's done by standardized testing, which is unapplicable for most of children with intellectual disability to be done because most of these tests are language-based tests. And this is where I found it some time, and this is where most of developmental pediatricians who are interested in intellectual disability population, that we're shifting from moving from IQ and we're looking more at function, because most of IQ testing are difficult to be implemented in our children. What's intellectual disability also mean that we have less effective coping and common life demands. We have difficulty in ability to meet standards of independence, difficulty adapting to a new environment, and difficulty with safety awareness, self-care, and communication skills. In this syndrome, there's a wide range of intellectual disability, and it ranges from mild to severe. And I looked in all the literature to see how they came up with that, and I didn't find anything to really indicate how they came that there is severe, mild, and moderate. They did not perform any adaptive or formal testing, so it's really based on basically information from parent and the case report that being done. And the thing that they looked at, it's mainly the speech and the early walking skills. But they did not look at, I would say, each developmental aspect in details. But this is how they're presenting it, and I think they also based it on what's known as highly function and low function, which is only used in education literature, and it's not used in medical literature. So what intellectual disability mean, and what's the result in? It usually means that the children or individual develop more slowly than their peers, and the degree of the delay varies, arriving at each stage of development at a later age and staying there longer, but that doesn't mean that they cannot develop the skills. The gap between them and their peers will widen with age because the demands on us is different as we grow older. In one big cohort in Italy, they look at 3 centers, and they looked at 1,161 patients presented with intellectual disability, and they found 11 that meet criteria for the nicolaides syndrome. And they found there's a variety of how they present with their intellectual disability and their degree of function. But it was fascinating to see that they are also part of that big cohort, and the presentation is similar to the presentation of other children with other causes of intellectual disability. With intellectual disability, what happened, there's a consequence of it, which is our children are trying to adapt their ability and their function. So they start developing avoidance strategy to face, when faced with a cognitive challenge. Their use of existing problem-solving skill are less than efficient. They have difficulty to consolidate a new acquired cognitive skill into their repertoire. They have increasing reluctance to take the initiative to learn, and they respond to encouragement is really vary from child to another. So there is reason of decline in IQ scores, and I put scores because we have to do a proper assessment before, and in this population there's no really standardized assessment being done to look at actual scores. But the basically proposed ideas for reason for the decline in IQ is uncontrolled epilepsy, and this is specific for any for this syndrome. The very slow development of speech and language is a reason of why we have decline in IQ score. And some early intervention programs have reported success in slowing or stopping IQ decline by doing effective speech and language therapy. And this is again because most of standardized assessment are language-based assessment. So comes here to talk about early intervention. With early intervention program, and it really varies according where you live. It's a variety of services across Canada, and we don't have even consistency in Toronto itself. But they're supposed to monitor the health. They have speech and language therapy, occupational therapy. They help with school entry and school transition. They also parent education, as they help the parent to become the effective advocate, expert to their child. Although some studies show that intensive early intervention could also cause parent stress, because there is a lot of demand on the parent to be put in parents, and there's too many people working with parents, and there's too many therapy in and out. The child will be in and out, which can be stressful for certain parents, especially if their children are medically complex. But we know that there's benefit of it. So it helps children with disability gains more cognition, physical, language, and social because of the therapy they implement and if they work as a team. It also helps the family, and it also benefits the society. Reduce the need for institutional placement, reduce the need for special education, as well as save money. So how many of you guys have been involved in early intervention services and find it helpful? Okay. And do you have the team approach to it?
We did with Kyle. I actually was very well with Kyle. I think it made a huge difference. When we saw Dr. Gia at 5 weeks old, literally the next week I had an early interventionist come to sleep with me at 6 weeks old. By the time he was 6 months old, I'd already gone through a program teaching me with speech, even though he wasn't a scholar for a while. And so I've got video every time we talk with an occupational therapist. So I think that has made a huge difference, that we got very good.
And is this applied for the parent with younger children?
You know, I think Helen's difference. This is what I've noticed since is the fact that Helen's trying to my students on a regular basis. I remember Andrew's
Yeah.
Still taking the same medication that he's taking, you know, but I think he's outgrowing it now, so maybe naturally is probably what's happening. But his seizures stop. They never happen every 2 weeks like they used to. And over a period of time, I noticed that he started to do that. He wasn't in that glazed over world anymore. And he started noticing people around him. And how can you teach and help a child to learn language when they're just off somewhere else? So that's what it is for Helen and our child. The difference where her child has speech, had no problem with, you know, and why
Yeah.
I think it's a fair comment to say that Kyle doesn't exhibit a lot of the autistic type tendencies as well, that you said that, you know, referring to, even though there's some little characteristics, it certainly that I think makes a difference as well. We're talking about with the early intervention.
It does make a difference. So with Mike, he's had almost everything. I just wanted to say, with Michael, looking at all of the lists of everything, aside from the problem with his heart, he's got everything. And he's still in diapers, he's nonverbal, his seizures are daily. But the early intervention, it might not have helped him as much when he was little, but it helped me because it sort of taught me on the times that he didn't have the seizures, what kinds of things I could do to interact with him, to help him to bond more and just to learn to move more and things with the, you know, physiotherapy part of it. Also the feeding part of it.
So there is definitely a correlation between seizures and development, and we see it all the time. Even when there is no nicolaides baraitser syndrome, when a child sees, then it takes the child back a few months, and we don't know for how long. And regarding the early development, we all as parents, good parents, have guilt feeling. Are we doing enough? And there's this kind of tendency, I'm going to sacrifice myself for my child. So you don't get out of your home, you don't go anywhere, because every minute is important for the child. And sometimes we lose this important thing, that if we will not do well, if our family will fall apart, if the connection between the couple will not continue, then the child is going to suffer. And I stress that out all the time. Take the time to build the connection between you and your husband or wife, otherwise the child will suffer. It's important for you to take a break, to take vacation, to build up yourself as a couple. I know you want to do the best, but sometimes doing too much is not good for the whole family. And make sure, especially the young couples, that you nourish yourself as a couple. Otherwise, the child will suffer for it.
Just going back to your comment about early intervention, I just feel sometimes it's frustrating when the child has too much medical issues and the therapy has to start within certain time and end at certain time. And like I know here, like the therapy end around age of 4. And it, like, if my child is being sick in and out, and if he's out of basically early intervention, then you are, like, you have nothing. And this has been a complaint from a lot of parents who, and we proposed the idea for a couple of early intervention, could we like change or make a shift of when to start, especially for children who have like really medically gone in and out to the hospital for many reasons. But I agree with you, this is frustrating. So then we move to the speech and language, and I like this tree. It's too complicated as well, just to tell the complexity of language. And when we look at the root down, I don't know if that's like really obvious. Like, to have language, we need cognition, we need also like sensory integration, executive function, joint attention, the theory of mind, the emotional regulation, and motor planning. This is all roots start with the child before even they start saying their first word. And even when we look at the language, that big tree, the language is not only the expressive language. And this is where like I have a huge debate with a lot of therapists and people with the nonverbal children. Language, they have three components to it. It is expressive, receptive, as well as nonverbal language. And just looking at the children who've been around us, just like roaming around us, you can see how much they talk just with their body. They are very expressive. They can tell you what they want just by their facial expression. And this is language. Every one of them, the three of them who were around, they told us a lot. They were interested. They were like, even with, I don't know which is the little one over there with the green shirt, when he was looking at the object and putting them in his mouth. It's not only mouthing. He was looking at it, inspecting it, feeling it, touching it around his hand, and then he was feeling it with his mouth. And he was exploring it. And like I felt, this is language. And the stuff he didn't like, he threw them on the floor. The teacher didn't like. And this is communication. So this is where like this tree, except like how complex language and communication could be. And it's only not the word that we say. So what's going on here with our kids? So their language is particularly limited. There's at least 30% of kids never develop expressive language or speech. Speech delay with the first word usually around 18 months. Mostly stay at a single word use. But me looking at the videos you have put in your website, I hope some of them gonna work. It's not only the single word they have. They have way more than the single words. But this is what's being reported in all I would say, the articles that I read. They have lots of repetition and word approximation, and a lot of repetition, it's part of them engaging in the conversation, and it's part of their developmental delay. 15% they lose their initial word, or they lose it later on in their life. Some related to seizures, which is really, it's also common in other population with children who have epilepsy and seizure. They may lose their language. And some of it, they said regression, and I put question mark about autism, because I have other theory about other causes of regression, like mental health or other psycho-emotional things that happen at home. So I am, like, especially with the older one, I don't think it is autism, because autism usually present in younger age. I think it may be depression, anxiety, losing a loved one, or being isolated. Because now when they're children, they're all around family. But as they grow, we don't know how the dynamics in the family change. So then when we talk about language, we come to social development. They differ widely. Most of children being reported as being happy and friendly, and I think the children here can prove that. They have different, and why this variety, it's really dependent on their temperament, how they are treated by others, and the experience in the family, school, and community. And also, like I always said, when we look at children with intellectual disability, the apple doesn't fall from the tree. And when you look at the parent, the children are really like their parent. In their temperament, what the things make them happy, even their comment, even how they move, or what the things they like. So I think we have to put these in mind and stop putting them in a frame and give these, I would say, conclusion that they are happy and friendly. So this is where, like, I just feel sometimes we have that stereotypic appearance to it. Severe intellectual disability likely to have, they have more difficulty with social development. Language development play a big role in how social and friendly you are. Joint attention. Do you know what joint attention is?
No, could you explain that?
Okay, so joint attention is one of the early, I would say, language development in children. Did you notice, like, children when you are in the park and your child gonna point to the airplane up in the sky and say, "Mommy, look, there's an airplane." So what he does, he's not just only pointing to the airplane, he's pointing to the airplane, looking back to you, and then following your eye gaze to make sure that you're looking at the airplane. That's what we call three-joint attention. And sometimes, if you notice a lot of children, if you're not looking, they will say, "Mommy or Daddy, you're not looking," because they check on you, or they're gonna move your face toward what they want to share with you. And what's the difference between joint attention pointing or grabbing your attention or regular pointing? We have two different points here. The regular pointing that develop early with children at around 1 year is pointing to request. They will point to show you what they want. And this is developed based on the child demand. They want to tell you what they want, and they're very demanding, and they're pointing to tell you, "I want a cookie, I want water, I want all that." So that's why they point. The joint attention pointing is to share a pleasant experience or a bad experience with you. And this is what promotes language. And this is where, why we use language, either to ask for my things, or to share an experience, and to do social development and to learn. And if I'm not interested to share something with you, I don't need to develop that complex language. I just can point to my demand and you will give it to me. And this is where the difference becomes where children who have autism and children who don't. Because even children with intellectual disability, yes, they may develop later their joint attention, but they're going to develop it. Yes, they're going to develop it later that they want your attention, but they're going to develop it in a later stages and ages of their language development. Children with autism, they do not develop joint attention. They do not want to get you, engage you, and share with you. But this is where, a lot of time when they said that we may have some autistic features, when we look at children with intellectual disability, we have to stop and pause and look over a longer period, and the diagnosis with children with intellectual disability and autism is not easy. And it's not like we cannot do it even earlier, because we know that they can develop some of the social communication skill later in their life. And this is again, a lot of when they're younger and their language is I would say not fully developed, their social communication are not fully developed, they can have some feature that can overlap with autism, but it's not necessary to be. So joint attention develop later in the second year of life. They have which can impact delay in the learning to understand words, and the earlier the development of the joint attention, the faster the development of expressive language. Because I want you to be engaged. I want that reinforcement from you. I want that engagement. And a lot of speech therapy now, with the individual with intellectual disability, they're targeting joint attention to start to developing it early. So this video, I don't know if it's gonna work. I don't think so. I'm just shift to the other presentation. I love this video because there's a lot of non-verbal language in it. We don't need sounds. Let's look non-verbal. So you can tell me the child what he's doing. Is he happy or not? Can you guys tell? Yeah. And how do you know that he's happy? He's engaged. What else? Yeah, you see how he's shaking his dad's hands? What else? Yeah? It's kind? Really? Yeah. So look at his hand. He's doing a lot of imitation. He's nodding. He's shaking his head. He's I think he's asking him to see the hat.
Up and down.
And then he didn't like it. He just moved it around. Like there's a lot of language going on here. And you easily can, without the sound, know, is he having a good experience or not? And how, like, what he wants, what he liked, and what he didn't. And this is where the best thing we can do, therapy implemented on following the child's lead in what he likes and what he doesn't. So he didn't run away, he didn't do any behavior, he was not aggressive, he's nothing, because he's really happy.
Okay, no.
So what are the important skills to teach young children with intellectual disability and language delay? We need to teach them communication skills to allow the child get their needs met, replace malbehavior, and engage in social interaction. We need to teach them nonverbal communication because that teaches that people faces and body carry important information. Also interactive play because it teaches flexibility, improve relationship, and replace self-stimulatory behavior, which can be mistaken to be like autism. So you can see them, they're flapping, they're spinning, they're doing all this, which just could be some of the repetitive behavior of autism, because it's not all the time. I'm not saying that they cannot have autism, they can, but we have to exclude these first. Then we come to behavior. So looking, like me reading between the lines, it seemed that there's no more behavioral difficulty than children of the same developmental ability. And do you know what I mean by developmental ability? Is if I would say like a child is developmental age is like 6 and he is 11 years old, but if I compare him with 6-year-old, he has no behavioral problem. But if I compare him with the 11, yes he is. So this is when we look at children with intellectual disability with behavior. I have to understand, is his behavior accepted to his developmental age? And then typically, there's no major behavioral difficulty if we start thinking in this way. There's some reported temper tantrum and a period of aggression, and my question is that related to language delay? Because if I cannot communicate my needs and my parent doesn't know what I'm saying, yeah, I'm gonna have a tantrum. They're gonna respond to me faster. If I indicate hundreds of times, I don't want to put that jacket on or that cape on, and nobody picked that up, and you put it on, like forcing me, I'm gonna push you away, and that's aggression. So this is where we need, like behavior is a communication, especially for children with nonverbal. What's the behavior mean? Why they're doing this? Are they trying to tell us something before start labeling it as bad behavior? So what's been described in the literature for our kids is temper tantrum, aggression, short attention span, which is very common with children with intellectual disability, especially the severe one, sensitive to loud noise, higher threshold for pain, and I want to alert to this one because I don't want that because of the children have a higher threshold with pain, we don't treat their pain, because then we're gonna see a lot of behavioral issues. And especially with if we need to do blood workup or all these things, we have to control the pain. Oral sensitivity, and this is when you talk about textures, things they like to put things in their mouth, and they feel it, and they like the textures. There's some reports say that they like salty and spicy food. I don't know about that. Yes? They have feeding difficulty, where much less common. Sleeping at night, awakening difficulty, is this common? Yeah. And do you know why? Do you try to figure out? Mm-hmm. Yeah. Okay. Yeah. See? Like you guys now analyzing it, see? It's not just because they want to wake at night and come to your bed. There's a reason. Yeah. Few behavior can persist and become difficult and may consider to be within the autism spectrum disorder. So now I'm coming here to talk about autism and the nicolaides syndrome. Some parents reported that they have autistic features. And I said, like, it's really, there's a lot of overlap between, especially for the severe intellectual disability and children with autism, especially if we're talking about, and I want you to think about it like that. If I have limited cognitive capacity, I don't like to change my routine. This is what I like. I like the sameness. I like to repeat what I know. I will play with my toy in the same way, and I don't like somebody to interfere with my way. Even if you are in the mild to moderate range, you are safe and content of things done in the same way, and that repetition make you more safe and content. Changing it will make a lot of children doesn't like transition. That doesn't mean that they don't have autism. And this is when we look at, if they don't like transition, that's fine. But if I can help them redirect and do it, and they are, I would say, responding to our treatment or responding to our behavioral modification, they're not going to be an autistic parent. It's really when it persists and affecting their function and affecting their performance, and we cannot redirect or change. There's like a number of cases being diagnosed with autism, but there's no formal assessment being made. And when we talk about formal assessment, diagnosis of autism, it's not only by observation. You have to do a full developmental history. We have to observe the child as a developmental therapist. We have to do cognitive testing to know what's the cognition level of this child is, and if his social communication skills are at the same level of their cognition, because if everything is delayed, I will expect their social communication to be delayed as well. And also, yes?
So do you think then that it's beneficial for parents if they go and get a second
Yes.
diagnosis of autism? Later, and I have been discussing it. I mean, certainly here, you're going to get more services and more funding is going into autism,
Yeah.
right?
Yeah.
So it is beneficial to do that then, yes?
It is beneficial because it gives you more understanding of the child, and we can apply advanced therapy. So we have a basic kind of therapy. It's known for children with intellectual disability, but to carry it to higher level, you need the diagnosis of autism. It just helps you to understand the child more. I don't like labels. Labels only for cans and jars. But the only time I could use the label to give me services, I'll use it. And this is in the medical and therapy world. In our world here, Kyle is Kyle. My son is the same. They're not changed. This is how they are. This is their personality. This is how we know them. We don't need to change them. And we parents adapt to their behavior. It's when they get out from home and we need now to let them learn, be more independent. We have to start looking at how we can get them more understood by others. And if especially we want to go to the school system, in order to make the therapist understand his behavior, the school understand his behavior, his peers understand his behavior, sometimes we have to label it. Just to give more understanding and to all of us be at the same page and work on the same recommendation. So there's a report in 2011. I couldn't find the actual study, and I tried and I couldn't. They described two unrelated kids with clinical features suggested of nicolaides syndrome and autism. But just me looking at the abstract, I think they looked at DSM-4, and I don't know, this is the Bible for diagnosis criteria. So we had one before the DSM-4, which is in 2007, I think, yeah? In the autism, they put language impairment as one of the criteria of diagnosis of autism. Now, in 2014, the new DSM-5, they took the language impairment out. And they just looked at impairment in social communication and repetitive and and stereotypic behavior. And the thing is, I don't know if taking the language out will make any difference in this population, because language impairment is one of the key features. They also looked at mutation in the BAF, I don't know how you geneticists pronounce that, complex, have been linked to the Coffin-Sayre syndrome, nicolaides syndrome, schizophrenia, and autism. So there is a link, and in the autism world, now there's a new thing coming called epigenetics, why autism is now being more common, because they think that we have certain genes that with environmental changes, these genes alter or trans change in a way that the features look like autism. And they found that these four disorders, there's a very good example for epigenetics, and I don't know if that's the link between autism and nicolaides syndrome. But there's a huge research going on in this area. And there's a lot of research going on in children with intellectual disability and autism. There's a huge research going on in Holland-Bloor Review with the province of Ontario for neurodevelopmental disorder, that they're taking all children with intellectual disability, autism, ADHD, and OCD, and trying to do a whole genome study of them, plus all kind of assessment, cognitive assessment, to see, is there a link? And what we can know more about these children. So putting it all together, we have behavior, we have language today, what should we do? When we have behavior, we have to know when it happened. Consider the reason. Is there something too much or too soon? Boring, repetition, child communication skill, emotion, is the child sad, scared, mad? And how have you enforced the behavior? We parents are very good in doing that. This is where it comes parenting skills. Children learn, if I will cry a little bit and my mom responds, next time I'm gonna escalate my cry to 100 and she's gonna respond.
And that is so true.
Yes.
I laughed with our Jaden, who's laying down and doing something, and he starts to have that funny cry, and it is just like I'm watching a little 2-year-old, because the minute I say, "Oh, poor baby, poor Jaden," he'll start to, and it's the biggest cry, but it's more and more because he knows he's getting
Yes. So this is in developmental peds and behavior we call negative attention is equal positive attention. And what we try to do is always teach the parent to reinforce and acknowledge the good behavior. Try to ignore the bad behavior, and ignoring by having that mask face, and also mirroring the feeling. So when we put it together, we have something called ABC of behavior. Any behavior, we have to analyze it. And I like how the example of the sleep. He wakes up because he has this. And I want you to think about every single behavior, why it's happened, is there something we don't know, and then what's the behavior and what's the consequence. What's the child is getting with that behavior. And that's what the children will start learning, how they're gonna behave. Also, we need to help them more by using visual support, help with transition and behavior, use behavioral strategies, and these are very good websites for visual and social story. With the kids who have more language, we usually do the teach language of emotion for cognitive effective training by Dr. Atwood. Do you know about that? Did you ever use it in the school? So it's used, this is where a lot of these things are used with children with autism, but it really can be applied for kids with intellectual disability because it's visual, interactive. You can customize it according to your need and help the children to be more aware of their thoughts, feeling, and action, and see how all these interact with each other. They have even chart. They have a feeling chart where you come and just point if you're sad, happy, angry, and it just faces. They have even a scale of pain. They even tell you, in a way, when you have these charts, if you're sad, what you need to do. So the non-verbal children or limited language, you give them option of things you like to do. So if I'm really sad or mad, I'm gonna sit in the corner. I'm gonna go and squeeze a ball. I'm gonna throw a ball in, so they reinforce the good behavior and redirect the child to different, and it's following the child lead. They choose what they want. Also teaching sign. Who of you believe in sign language?
I believe every word.
Okay, okay. Yeah, okay. So did you use the sign language, the simple sign language, or the sophisticated one? Perfect, okay. You use the baby one? No? Okay.
It's hard for the fingers,
Yes.
even though, because
Yeah.
even with the baby sign language,
So did the speech therapy try to change that?
Try to change.
So for example, more is like this. But did they ever thought about more like this?
We did do that.
Okay.
He was kind of doing.
Yes.
So there was some.
Perfect.
But
So this is where we need to be accommodative. Because the sign language, when they started, I don't want the one for the hearing and deaf, because that's way complicated. The baby sign is, sometimes it's really complicated for our children. It's whatever the child would have. Sometimes they can create their sign. My son created thank you like this. And he created from an Indian taxi driver. And we moved it all along. This is thank you. It's not like this. And I found sorry and thank you is confusing. So make the sign that you teach simple. Teach that can be immediately reinforced. Immediately, you don't need to wait. Choose iconic signs to begin to look at the object and then relate it and still using the word. Make sure all those are in the child environment and he knows them. And signs, I would just use signs for avoiding frustration, like no, yes, more, potty, open, up, down. Yes.
When Mike was little, I wanted to get him to express himself more. And I knew what his mood was like, but he needed to be able to express it, so I taught him angry, but I was very, my face went with it and everything, and we made a game out of it, so it's like happy, sad, angry. So even if he hears so we worked on that, and if he starts getting upset, I'll go over and I'll say, "Are you angry?" But I use angry for frustrated, angry, like all of the negative kind of things. And as soon as he expresses that, he smiles and he comes out of it.
Yeah.
So
Because you mirror the feeling.
yeah, so that was really helpful.
Yes, we parents are not good in mirroring the feeling. We have a child fall down and say, it's okay. No, it's not. I fall down. Why not? We can say it hurts. You don't need to, and don't say I know, because we don't know. It's the same if your friend coming to your house and she's really frustrated, she had a bad day. Would you ever to her, it's okay, I know it's a bad day? No, you would sit down, you will look at your friend and you will say, oh, it's really it's been hard, it's really a bad day. So why we don't do this with our children? So I found a lot of behavior. I have 3 children. My younger one, who's typically developing, I always call him my behavioral child. I have to take triple P. I don't know if anyone is familiar with this. It's for parenting. I read 5 books about parenting. And my end of conclusion, I just need to mirror his feeling. And it works. So, this is exactly what it is. You, when he's sad, you mirror sad. And he's happy because you acknowledge his feeling. And this is also has to be, I would say, transformed to everyone work with the child. To the school, to the therapist, to the teacher, to everyone. So that child have consistency in the response and the immediate reinforced, all his things. Other ways of teaching, anything use. I just like to say anything. We have picture exchange communication system for children with nonverbal, assistive and augmentative technology, communication board, reinforce all vocal attempt as word, even if it's a word approximation, and acknowledge it. Use imitation, use music, use book, use the iPad, follow the child leads, use the child interest. Okay? And the main thing, move in and out from your comfort zone, but don't go to the over edge, then we will have them collapsed on us and they will react. But you move in and out at what the child can give you, and this is when we say, follow the child leads. He's gonna tell you when it's too much and when it's too little. Then this is my other video. So maybe we'll see the videos after from your website. And this is the video I love. I don't know if you guys, did you see that one? Yeah, we'll open the video, but this one show you how imitation allow the child learn from environment. This is the TV is there and he is dancing beautifully, just like the dancers. And we will look at it at the end. So there's the other approaches, which is these things have been used with children with intellectual disability and autism, but I found them very, very helpful with children with intellectual disability. The ABA, which is the Applied Behavior and Analysis, Applied Verbal Behavior, the Floor Time DRI, and the Early Start Denver model, which is a new model now being used, and this is a combination of all of the above. And the whole idea is follow the child leads and make the interaction make sense and enforce the child, so they really can learn and engage in their environment. And I can go, each of one will need a presentation by itself, so I just put them there. Then the other method, which is common, and it's common here, and most of our speech therapists use it, the Hannon method. I don't know, anyone familiar with it? Anyone took the course? Perfect. So it takes two to talk, and it's more than words. Here in Toronto, it is within the speech therapy block. So all the parents, once they are involved in the Toronto Preschool and Language, they're eligible to have this workshop. And it's really good, where it's an 8 weeks workshop in the afternoon, in the evening, and two parent has to be there. And they're very sticky that two parent has to be there. And then they video the child interaction with the parent 3 times during the course. And then the parent look at their videos and criticize themselves, which is very good. Which teach us that basically we do a lot of things. We thought that we're communicating with our children and we don't. So the whole idea is teaching communication and play skill through adult and child interaction. Parent and therapist are to observe, wait, and listen. The child lead the teaching and the leads, and the teaching is conducted based on the child's interest and needs. So it's a very, and they have 2 books. They have It Takes Two to Talk, which is an early book for most of children who have mild language delay to moderate. And they have It's More Than Words with children with severe intellectual disability and also autism. Then motor skill, and I put that at the end because all our children are good in motor skills, right? They're all walking, they're all sitting, and this is what the literature just focuses on. So when we look at the motor skills, the majority achieve all basic skills, sitting and walking. Same sequence as the typically developing children, but later, and this is mainly related to the hypotonia. They improve, we know that motor skill improve with practice. There is considerable individual variation in the rate of progress, similar as all of us of the motor ability. Some of us are like athletes, some of us are not, and that's variation. The recreation skill also vary according to the parent interest. Some parents are really athletics and they go and do a lot skiing and skating. The child has to fit into that environment and they'll do it, and some other children not. The balance seemed to be a particular difficulty relative to the progress in general coordination and muscle strength. And this is related to the hypotonia. We call it the higher motor skills. And if we look at children with intellectual disability as well as hypotonia, the higher skills are usually that difficult to achieve. And this is where I put the note here. In older, and I just took it the way it is, in older individual, slowing down movement has been reported. And the only report, when they report the first case being reported with the nicolaides syndrome, she started using a wheelchair when her seizures were uncontrolled. But before that, she was moving and she was in and about. So I don't know what the older parents think of the slowing in the movement.
Mikey actually keeps on going. It's just recently he's had a problem with blindness, so he's unsure of unsteady on his feet. But the only time we usually use the chair is if we go on outings.
Okay.
But now we've had to use it a little bit more often.
Yeah. I went recently to a Down syndrome medical interest group conference, and the neurologist present catatonia, which is like stopping in the movement and moving pattern change with older children with Down syndrome. And I don't know if that will be applicable for all with intellectual disability. And it's been also described in older children with autism. So there's really nothing written there much about, but it's something to look as the children are growing.
How can bike, skateboard,
Yeah.
longer, and nothing?
Is the bike video yours?
is the one coming?
Which I can't put it there, like it's not coming, but I put it there also.
I think, yeah, I think we
Yeah,
want
okay.
the one, I don't,
Okay.
yeah. But no,
Nothing here either. Like
is
with
Dana.
horseback riding, it's all,
Yeah.
it's maybe getting better if anything.
See, this is joint attention. She asked me what my name, she grabbed me to look at me, I love it. Can you see mine? What? What color is your sandals? I can't see them. Oh. So this is the bike.
Oh, no,
That's not you?
Kyle. No.
Okay, but this is really cool. So, learning specific movement. Children, this is applied for kids with hypotonia and intellectual disability. They're slower to react and initiate the movement. They're slower to complete a movement. They're more, I would say, less accurate and having more error. And the reaction time improve with practice, but the reaction time is slow. So this is when we talk about higher skills. So health conditions that can affect the movement, visual impairment, hearing impairment, and control epilepsy, failure to thrive, because if they're really skinny and thin, they cannot keep up with the activity, and their physical characteristic really affect their recreational choice. If I have issues with my hand and I can grab things, I'm not going to be a tennis player, and all these kind of other things. So physiotherapy is important. It will not make them walk earlier. It just avoid the negative compensatory postures from developing, like turned out legs, lower the gait, sitting with a rounded back, work on balance and coordination. And in the older groups, I usually suggest to have a group therapy together, because that will promote more activity. It will help their social skills as well. I know I'm running out of time. Occupational therapy to promote self-care, feeding, dressing, and grooming. Skills related to school, performance, play, and leisure skill. And the best thing is to have the OT, speech, and PT work together as a team. So what do we need as parent and teacher and educators? We want the kids to be happy. So there is a book, I like this book, I read it myself. It's called The Dance of Parentship. And it's Why Do My Feet Hurt? It's basically for kids with special needs. And it's do you hear what I hear? Parent and profession working together with children with special needs. And it's really, they have some of the stories and things that we share about our children. And it's a dance. And you need to learn the dance, how to dance it with the school after, right? So most of us want them to say, to say my name. I wish she could tell me her thoughts and wishes. I want him to play like other kids and have friends. I want him to read. I want him to be successful at whatever he wants to do in life. And I want him to pay attention and learn at school. Do we agree all? So the idea is use whatever works to teach the most important skill to each child at the given time. Just use the time that you are in. Don't worry about the future. The future will come. But if we take small baby steps and we work at short goals, we're setting our children for success. Because we are celebrating every gain they do. Because this is what's the goal. We achieved it. If we put unrealistic and long-term goals, we just put ourselves in that cycle of emotion, and we are not setting ourselves or our children for success. And the main thing I usually look at, social, communication skill, and civil behavior are the foundation to the future social, emotional, cognitive, and academic success. And I will end it here. Any questions?
We covered quite a bit there. That was amazing. Thank you.
Yes, thank you.
Thank you.
Is there a way to get your PowerPoint by chance?
What?
Is there a way to get your PowerPoint by chance?
Yeah, you can take it now.
Can we
put it on
possibly
the-
put it on
Yes.
all the PowerPoints, put them on the website possibly?
We put it in a PDF form.
You like my
Yeah.
Okay.
I like
Yeah,
yours.
that's nice. Thank
Can we switch? I have a
Okay.
bowl too.
So we go to the last, but not least. Talk. Shona, thank you very much for coming. Sweet. So, Shauna grew up in Newfoundland. Anybody from Newfoundland here?
Yeah.
Right. And graduated from the Memorial University of Newfoundland Medical School in 1994. She did her residency in pediatric neurology here at the Kids from 1994 to 1999. She has consultation clinic at St. Joseph Health Center in Toronto East General Hospital and Humber River Regional Hospital. She lives in Toronto, and one of the most important achievements, she is a mother of two. And Shauna is going to talk to us about seizures and epilepsy, a guide for parents. Shauna? I hope that we will be able to put together all the internet things that she... Where is our guide?
I have it on USB. It's easier. Yeah. So what I did, I opened my Dropbox and I...
He probably fall asleep.
But he refused.
Your USB is still in your password.
And he doesn't care about anybody. Layla. Kyle, we're just talking about you. You know what I'm saying about you?
What?
I'm saying that all you wanted to do was play with every other child, all the little kids. And Jessica comes in, and guess what? Nobody else matters.
All about the girls.
Kyle?
I don't really care about it.
You don't care about it?
Not interested in this conversation.
What did you say, Kyle?
I'm not interested in the conversation.
You're not interested in it?
Boring.
No, I asked him earlier how it was. He said it was boring.
We don't take
We're
it
gonna
personally.
entertain her here.
Trying to have an app.
Oh, that tells me the next one. Yeah.
If anybody wants to get on the Wi-Fi, the password is be our guest. BEOUR.
Hello? Is that good?
Okay,